This is an inverted vitrectomy procedure. Vitrectomy for the management of a giant retinal tear. This is a 55-year-old pseudophakic patient undergoing a 23-gauge Plana vitrectomy. A core and peripheral vitrectomy is initiated, carefully separating vitreous adhesions from the retina. Mild vitreous hemorrhage and posterior vitreous detachment are observed. Special attention is given to avoid traction on the highly mobile retinal periphery. Despite the macula being off, an early approach is essential to avoid proliferative vitreoretinopathy, PVR. PVR could be a late complication of giant retinal tear and a leading cause of surgical failure. Increased access to the retinal pigment epithelium allows more cells and pigment to escape into the vitreous cavity and the retinal surface, raising the risk of PVR. As evident, the vitreous is highly condensed at the base, with the capsular opacity concealing a portion of the inserted cutter at the entry site. The image shows the retina folded over the macular area. The tear's edges are very close to the peripheral retinal vessels, requiring close monitoring to avoid contact and potential bleeding. With a large tear like that, the anterior insertion of the retina loses peripheral support, causing the retina to fold back on itself. Additionally, the retina tends to roll due to the lack of vitreous attachment. Perfluorocarbon liquid PFC is injected to flatten the retina. It comes in multiple bubbles, so injection should be slow. A safer approach is to use a 10 cc syringe for the injection, ensuring the string does not forcefully impact and harm the retina. Endolaser treatment is the next step, targeting the retina lining directly. Endolaser treatment is performed using perfluorocarbon liquid, which provides excellent visualization. A wide-angle vitrectomy viewing system provides excellent peripheral visualization. Additional PFC is injected to cover the retina up to the extreme periphery. A 23-gauge cannula is used to remove PFC and replace it with silicone oil, performing a direct exchange. The action should be performed slowly to avoid dislocating the retina, ensuring it remains in the correct position and preventing any rotation. The exchange begins at the very periphery, preventing perfluorocarbon from entering the subretinal space. Silicone oil has been proven to be more effective for early visual rehabilitation and is safer to exchange with perfluorocarbons. Although tiny bubbles that didn't coalesce upon injection need to be dealt with, patience is crucial to remove them all. Using a macular lens ensures none are missed. Maintaining a slow pace is essential to avoid retinal dislocation. Finally, the retina must be thoroughly examined. By inspecting the retinal periphery and through the air bubble in the vitreous cavity, an effective laser can be observed along with an attached macula and no retinal slippage, achieving the desired intraoperative result. Square sutures were put at the end. On postoperative day 7, the retina is fully attached. There are some peripheral hemorrhages, likely from leaking retinal vessels. The macula is unaffected and looks pretty good. I appreciate your attention. Thanks.